Well, we got a couple minutes for a little panel discussion. Those were all really great presentations. Anybody from the audience want to, RJ, step up to the mic?
Just one short question. When you do the reperfusion of the heart, what flow rate do you use at 24 degrees? You know, when you do the David procedure and you reperfuse the heart, what flow rate do you use for that?
So the temperature is 24,
Yes.
and it's very important that the vent is in the ventricle, because we don't want any dilatation of the ventricle, and the pressure, because we've done a valve repair, it should not be more than 75 millimeters of mercury. We don't want 200 millimeters of pressure and then the valve get,
How do you measure the pressure in the root, just for that side?
The pressure is, I have the second line with the pressure. The flow is dependent on the pressure. In some people, if they have big hearts, you can have 400 milliliters, some people only 200.
Great. Another question over here?
Thank you, Dominic Perry from Hamilton. I have a question about a family that I'm following with ACTA 2. It started with an aortic dissection in a sort of 50-year-old male, and there was also a family history of sudden death. And then so we've got an autopsy clinic. We did the genetic studies and found that there was ACTA 2 in the family, and now we've discovered there's about 6 or 7 family members. Quite a few of them are young females, and one of them was another female in her mid-60s who I actually operated on at about 4.4 centimeters ascending aorta. The question is about the size to operate on them and the extent of how much aorta to replace. This woman had a 3.5 centimeter root, completely normal valve, normal sized arch. It was just a isolated ascending aorta. But should in these sort of ACTA 2 cases, should we be doing more extensive operations, getting into the root and up into the arch when it looks like a completely normal size, really, or should we just really be treating the area that is slightly enlarged at the time of assessment?
We got a large series of ACTA 2 patients in Cleveland, and it's interesting. A lot of them will have distal dissections at more normal-sized aortas, and so it's very hard to predict. I think the simple answer is you do what you think is safest at the time of whatever's indicated, and make sure you have them plugged into a good follow-up program. How big did you say the root was?
About 3.5.
Yeah, I think I might just leave that alone, because once you have the ascending sort of replaced, you sort of protect them from a type A dissection, and if the root grows, then you worry about root rupture risk, which could be very far down the road.
Yeah.
Having said that, I've got a couple of patients who are ACTA 2 who, one that comes to mind right now is a young lady who I did a David and an ascending on, but I had also operated on her dad for an acute dissection. And it was a distal dissection that kind of went, this B0 kind of thing that Chad was talking about. And so when I did her surgery, I did a zone 2.
Right.
And it proved to be, a really brilliant move by me because she showed up about 2 years later with a new dissection, and she was malperfused, and we were able to just stent graft that and then kind of monitor everything. Yeah. So it's a little hard to know. I think you look to their family histories, though, and see how other family members act, and that might give you some semblance of sort of understanding things. If you know, like, what size someone dissected at, that can help a little bit. And then the other thing with ACTA 2 patients is they're also prone to develop coronary disease, so you got to appreciate that as well.
Thank you.
Till we get another question, I'll make a couple of comments. One, I think on these genetic issues, and we're finding more and more of them, and we're beginning to parse out. I mean, Loeys-Dietz was just Loeys-Dietz. Now it's a series of different TGF-beta issues, et cetera. I can make a case for being fairly aggressive on those patients because they're going to be coming back. We also have to keep in mind is once we're getting to see more and more information on this. Once we replace the aorta with a rigid structure, the energy being transmitted down to the remainder of the aorta is increased because the elasticity is gone which absorbs some of that energy. So the impact to the distal aorta, or in the case I showed, the other way around, has to be taken into consideration. So careful follow-up, I think, reasonable to be aggressive in these cases. The other thing that I like to think about in these patients, connective tissue disorder specifically, or hereditary aortic disease, depending upon how you look at it, is that we like to take, it's very important, you've seen a lot of this, we like to take branch grafts off of the arch and go to these distal brachiocephalic vessels out to the subclavian, axillary, carotid, et cetera, because if you have a recurrent problem later, you really want the problem to be not an arch problem. You'd want it to be a distal problem that is much easier to manage. Otherwise, you know, we talk about all the great results with redo arch surgery, but it's still worth avoiding when you think about how you're planning out the long-term care of these patients. Over here.
Dr. Roselli, Marco here. Question for the panel. After all that's done and somebody got stents or whatever, 6 years, 7 years, 10 years down the road, they come with hemoptysis. You work them up and maybe has just pseudoaneurysm and you think you can go with an endograft and cover, and you do cover. What will be the recommendation? You have to assume you have like a microfistula or a fistula connection. Is there a role, or should we put them on antibiotics, and for how long? It's a IV for 6 weeks and then PO for a year. What are your guys' experience and recommendations on that?
Puja, why don't you handle that one? You showed that case.
Well,
Clamshell
I
case.
think definitely if you have an esophageal sort of fistulous connection to that, I would say obviously an explant would be the best operation. Now people have treated, you know, some sort of infectious TVARs with long-term suppressive antibiotics. I don't think those patients long-term do obviously very well, probably don't have the follow-up in them. The bronchial fistulas, I think those are a little bit, you could probably go either way as long as, you know, they don't have a, you know, chronic pneumonia, empyema, or an associated sort of abnormality of the lung. You could. I think my personal preference has been just to continue patients on suppressive, but I think that's also possibly a little voodoo too, so.
Well, the second was, since you're on the microphone, now we have one that it was probably a esophageal fistula, which this was quite a bit of inflammation. When we went to do the thoracoabdominal, we were hoping for pulling that stent out and come easy, but that was not the case. And we felt ourselves that we have to leave a remnant of that endograft to do the anastomosis. And you know that that's quite, in the long term, futile. Any recommendations in the technical standpoint to be able, like cutting it, folded it in itself like a sardine cane or something like that? Because, you know, if you leave whatever you leave, it's going to be a sentence.
Well, I think, you know, if it was hard to get out, it's possible that the whole thing isn't infected. It's just that, I mean, there's literature on removing part. I mean, I'm not advocating that, but there are case reports of just removing part of it and having long-term success that, you know, the whole thing, because usually if a stent graft's infected, it comes right out. Like, it's not hard.
Well, that's what we were hoping,
Yeah.
but that was not the case. It was adhere to the subclavian area, and you could feel that if you pull it out, you will bring all the endothelium.
Yeah, I mean, there's reports of leaving part of it and so, I mean, you got to do what you got to do, but obviously that patient needs to be on suppression forever. But, you know, it's like 50% mortality that getting them through all the stages anyway, so, like, you know, it's not like high success rate with that problem.
No, they more likely will die with the infection.
I just have one comment, and certainly don't have significant experience on this, but for a handful of cases for those infected TVARs that are more proximal, we have done an ascending to abdominal bypass and then ligated the aorta and the arch and then come back for an explant. And so it's a staged operation, and all the patients we've done survived. But, you know, it is a rough recovery. It is a staged operation, but there are options if you can't expect.
Dr. David, you want to make a comment?
Puja, to reply my point, I haven't done thoracic aorta for 10, 12 years since Maral joined us. But all the infected cases, you used to do a sending aorta abdominal bypass, flip the patient over and take the stent or the infected graft. I I don't know how many in my career, 10, 12 cases, but I don't remember anybody to have died. in
Well, there
hospital.
was, in the 5 that I followed, all of them actually developed heart failure, and I was just wondering, potentially there's an afterload issue, because now you're just sort
But the
of,
graft has to be large, yeah, Puja.
I mean, we put,
I always believe
24,
At
26.
least, well, yeah, 26, 28. There's a long way to go.
Yeah.
It's an incredible afterload for the heart.
It's called anterior aorta. I just
Yeah.
reviewed a paper, a big series of them that had very good results. I mean, I think it's probably the way to go for that problem, because there's no good answer for that.
Yeah, that stump blowout's an issue. You need infection control is what you need, and if it's the esophagus, you're gonna have to take a bunch of the esophagus out. Whether you can leave some stuff behind, Marco, I don't know, it's possible you can get away with it. We'll put momental flaps and lifelong antibiotics, and if it's esophagus, it's a horrible problem. And if you haven't seen them die yet, they're gonna die. Like, they're not gonna have a normal lifespan. Hey, Joe?
You're talking about stumps. I think when I was a general surgery resident, I asked Dr. Szilagyi, who wrote a lot of infrarenal resections and extra-anatomic bypass. I asked him, off to the side, how many of those stumps blew out, and he said, son, all of them eventually. So it's kind of, I used to get a few thoracos from Toronto once in a while, but Morales cleaned that clock for me. I'm going to bring up another just real quick issue. We're running out of time, just for virtually anybody on the panel, and that is that when Craig Miller and Dr. David would take an acute type A dissection to the operating room, if malperfusion didn't knock off the spinal cord, and their legs working, when they went into the operating room, they came out of the operating room, the legs were fine. There's no large series that I'm aware of when we started sticking these rigid stent grafts down into the descending in these cases that doesn't have some paraplegia, which is, Dr. David pointed out earlier, that how devastating that is. Y'all's thoughts on that? Just go down the panel and...
Yeah, I mean, we've seen one, Joe, and the patient was compromised when they came in. I think you got to go cold. Low moderate is cold. However you describe it. You got to go cold, and you got to keep a short stent graft in if you're going to do that.
I mean, you're just saying, in hemiarch for type A, basically you don't get paraplegia. Yeah. Yeah, the only time I've ever seen it was delayed, where they thrombosed, you did a hemiarch, and they end up thrombosing their false lumen, delayed, and they got delayed paraplegia from that, but it wasn't from the hemiarch.
So, two of you presented some Thoraflex cases. In the Thoraflex trial, there weren't any acute dissections, so it's a little bit off of that. But in the 10-centimeter grafts, there weren't any spinal cord problems. In the 15, and these were not acute dissections, they were just regular aneurysms, there was some paraplegia.
Yeah.
Did they revascularize the synclavian and all that?
Don't know. I think they were all revascularized. I don't think anybody left a subclavian alone. Yeah.
Yeah. I mean, I have no experience with the beyond the 10 centimeter, and I don't do endo of the descending, but in an acute short, as long as there's perfusion around majority of the spinal vessels, not acutely thrombosed, then I would say it would still be low, but I haven't seen one yet.
Malakh?
Yeah, at least from the Hanover data from 2012 to 22, when I left Hanover, we had about 80 frozen elephant trunks with Thoraflex. We had 0 paraplegia, because what we do that we learned to do at zone 2 and use only 10 centimeter grafts. So basically only 7 centimeters is beyond the left subclavian. So it's a very short graft, one. Second, we try to keep the blood pressure high post-operatively also, because one of the things that we made a mistake in initially was that because they were dissection patients, we wanted to keep the blood pressure below 110, and it's bad for these patients. So what we learned was that just go up to 130, even 140, because if your anastomosis is good, it will not bleed at 140, right? So, and then that's the thing.
If you look closely at those series that have higher numbers, they had really long circle rest times, too. I think people have gotten better about that.
Yeah, they've usually had longer grafts, too. It's been a great session. We're going to have to move on to the case presentation.